Going to discuss the Vasa Previa Guideline Diagnosis and Management. In the introduction and background epidemiology, we have some important things which we need to remember. Okay, when does Vasa Previa occur? Vasa Previa occurs when the fetal vessels run through the placental membranes and unprotected by the placental tissue or the water jelly of the umbilical cord. A Vasa Previa is likely to rupture in active labor or when amniotomy is performed to induce or augment labor, in particular when located near or over the cervix under fetal presenting part. Now there are two main classifications of Vasa Previa. Vasa Previa is classified as type 1 when the vessel is connected to a velamentous umbilical cord, and type 2 when it connects the placenta with a secundariate or accessory lobe. Okay. Now, Vasa Previa, how is it diagnosed? Vasa Previa may be diagnosed during early labor by vaginal examination, detecting the pulsating fetal vessels inside the internal os, or by the presence of dark red vaginal bleeding and acute fetal compromise after spontaneous or artificial rupture of placental membrane. Okay, so in early labor, if we find dark red blood, whenever we do either vaginal examination or fetal compromise in case of artificial or spontaneous rupture of membrane, then it should click our mind that probably this is Vasa Previa. Okay, it's a very serious situation, and it's written that the fetal mortality rate in this situation is at least 60% despite urgent cesarean delivery. However, improved survival rate of over 95% has been reported where the diagnosis has been made antenatally by ultrasound followed by planned cesarean section. Okay, and Vasa Previa is uncommon in general population with a prevalence ranging between 1 in 1200 and 1 in 5,000 pregnancies, although the condition may have been underreported. Now, how would we manage a woman with undiagnosed Vasa Previa at delivery? Okay, emergency cesarean delivery and neonatal resuscitation, including the use of blood transfusion if required, are essential in the management of ruptured Vasa Previa diagnosed during labor. Okay, and placental pathological examination should be performed to confirm the diagnosis of Vasa Previa, in particular when stillbirth has occurred or when there has been acute fetal compromise during delivery. Now, can Vasa Previa be diagnosed antenatally? Yes. The performance of ultrasound in diagnosing Vasa Previa at the time of routine fetal anomaly scan has high diagnostic accuracy with a low false positive rate. And a combination of both transabdominal and transvaginal color Doppler imaging ultrasonography provide the best diagnostic accuracy for Vasa Previa. Now the question arises, should we screen for Vasa Previa? And the answer is that there is insufficient evidence to support universal screening for Vasa Previa at the time of the mid-pregnancy routine fetal anomaly scan in general population. And although the targeted mid-pregnancy ultrasound assessment of pregnancies at the risk of Vasa Previa has been investigated, the balance of the benefit versus harm remains undetermined, and further research in this area is required. Now coming to the main points of the management, how should the woman with Vasa Previa be managed? Okay, there are very important points. First of all, because of the speed at which fetal exsanguination can occur and the high perinatal mortality rate associated with the ruptured Vasa Previa, delivery should not be delayed while trying to confirm the diagnosis, particularly if there is evidence that fetal well-being is compromised. Now, in the presence of confirmed Vasa Previa in the third trimester, elective cesarean section should ideally be carried out prior to the onset of labor. Now, a decision for prophylactic hospitalization from 30 to 32 weeks of gestation in the woman with confirmed Vasa Previa should be individualized and based on combination of factors including multiple pregnancy, antenatal bleeding, and threatened premature labor. Now, in cases of Vasa Previa that develop premature rupture of membrane and or labor at visible gestational ages, a cesarean section should be performed without delay. Now, to avoid unnecessary anxiety, admissions, prematurity, and cesarean section, it is essential to confirm the persistence of Vasa Previa by ultrasound in the third trimester. Now, at what gestation should elective delivery occur? The ultimate management goal of confirmed Vasa Previa should be to deliver before the rupture of membrane while minimizing the impact of iatrogenic prematurity. Okay, and based on available data, planned cesarean section or prenatal diagnosis of Vasa Previa at 34 to 36 weeks of gestation is reasonable in asymptomatic women. Now, there is a role of corticosteroid as well. Administration of corticosteroid for the lung maturity should be recommended from 32 weeks of gestation due to increased risk of preterm delivery. Now, in the end of managing the whole case of Vasa Previa, it's very important to come to the clinical governance point in which we do debriefing first of all. Secondly, training should be given importance, and third, clinical incidence reporting. Well, debriefing means postnatal follow-up should include debriefing with an explanation of what happened and why it happened, and any implication for future pregnancy. Training. Raising awareness about the clinical risk factor of Vasa Previa should be pursued locally, including the organizing policies or guideline or flagging of women at the risk and arranging for them to see specialist consultant when suspected. And there should be appropriate training for ultrasound staff in the antenatal diagnosis of Vasa Previa. The third very important thing is clinical incident reporting. There should be a written protocol for identification of and planning future care of the woman diagnosed with the Vasa Previa. Okay, so this is all about the RCOG guideline of Vasa Previa. Thank you so much for your patience.